Go ahead, ma'am.
Yes. Hello, everyone. I am Dr. Ashwini, Infertility Specialist in Oasis, Vakad, Pune. So, happy Holi to everyone. And today, my topic of discussion is non-surgical treatment of endometriosis. So, for that, we should first know what is exactly endometriosis and how it affects the life of the patient, and what is the management. That will be the last part which I will explain. So endometriosis is nothing but the endometrial tissues which are present normally inside the uterine cavity that deposited outside the uterine cavity, and it means it shows a cyclical hormonal patterns, and according because of that the patient feels severe pain. That is the one of the what we say clinical sign when the patient came with a cyclical pain. Then there is a menstrual irregularities there. Some patient they are having a polymenorrhea, some patient they are having a menorrhagia. So this will indicate yes, this patient can be the patient of a endometriosis. So endometriosis, how it comes, from where it comes. So there are so many theories which will be explained by the various scientists, we can say. So one of the famous theory is the Samson's theory. So that is means ki retrograde menstruation. When the menstrual cycle is there, periods are there, so they goes retrogradely, and it deposited outside the uterine cavity, mostly in the uterosacral ligament, sometime in the ovary. And these causes typical means pain. There are the signs, means we call, there is a triad for the endometriosis. In that the patient is having a dysmenorrhea, it is having a dyspareunia is there, and the deep seated pain is there. So dyspareunia, what is dyspareunia? It is a pain during the intercourse. So these are the few clinical points for that we can say yes, this patient is the endometriosis. So there are theories which I told ki one is retrograde menstruation, that is we called it as a Samson's theory. Then in certain patient when there is a natural killer cell activity is more, so it is a logical factor is also there ki because patient ask ki madam मला का endometriosis झालं. So I am explaining the reasons. And the second is what we say genetic. When your first degree relative, like if the mother is suffering from the endometriosis, so it increases the risk 7 times more to that daughter, means to her daughter, ki she will also suffer from the endometriosis. So there are the types of endometriosis. One is of pelvis, means because our uterus, our ovaries are in the pelvic cavity. So in the pelvis there is a peritoneal, ovarian, and deep infiltrating is the type of endometriosis. And in the extra pelvic, we can say it can deposited in various organs like a urinary tract, or sometime in the bowel also. The bowel endometriosis causes a severe pain, sometimes in the vagina, sometimes in the thoracic region also. That endometrial tissue get deposited, and it causes a adhesions, it causes a pain to the patient. And clinically, which I am telling from the first to side, ki pain is the main symptom which is associated with the endometriosis. Then other symptoms like abnormal bleeding, and the most important is infertility. So infertility, we know when the patient is trying for the pregnancy for more than 1 year, it occurs, then it called we as a infertility. Because what happens in endometriosis, because of the cyclical hormonal changes, that endometriotic tissue which are deposited outside the cavity, they causes adhesions. So because of the adhesion, the normal physiology of our fallopian tube, or we can say when there is on the ovary, the endometriotic tissue get deposited from the endometriotic cyst. We called it as the endometrioma. Or when we see that endometrioma, when we do laparoscopy, and when we puncture it, it causes some chocolate material outside that cavity. So it is commonly said as a chocolate cyst. So that chocolate cyst that affect the ovulation, that affect the normal adhesions inside the cavity, it causes adhesions. And because of that the patient have the means problem in difficulty to conceive. and these are the patient which endometriotic patient, they got conceived by the IVF, because in IVF what we do, we put a embryo inside the uterine cavity, so there is a less involvement of the fallopian tubes, and once we get a good quality of the embryo, so the result is also good in this patient. So for the management and how we diagnose ki yes, this patient is having endometriosis, so when any new patient, she's coming in the OPD giving me the typical history ki madam, I am having pain, I am having difficulty during the intercourse, I am having a other menses related problems. So the first what we do is the transvaginal sonography. Transvaginal sonography, it is not a gold standard, but obviously it will say ki whether there is any cyst. The cyst of the endometrioma is a typically ground glass, and the patient having a pain, will we put a probe inside because of the ligament which are supporting the uterus, which are supporting the rectum, they are infiltrated by the endometriotic tissues, and that causes an adhesion, and patient having a typical pain when we do the transvaginal scan. The gold standard for the diagnosis of endometriosis is definitely the laparoscopy. Now, why laparoscopy? Because during laparoscopy, we can directly see the endometriotic lesions. They are a deeply brown in color. When the chocolate cyst is present, we can remove in that same sitting only. So that is the thing, and we can do the MRI scan also. On that also, we can diagnose the endometriosis. Even the transvaginal scan, it shows 70% yes, patient is having a endometriosis, there is adhesions is present, and gold standard is definitely the laparoscopy for the diagnosis of the endometriosis. So management typically depend on the patient age, the patient symptoms ki what exactly patient is want, because if the patient is young, she is having a infertility, and when during infertility if I diagnose the endometriosis, so the management changes. If the patient completed the family, so the management changes. So it totally depends on the patient age, the patient requirement. And there are the mainly, when we manage, there are two types. One is asymptomatic, means patient is having endometriosis but she doesn't know about it, so we tell ki okay, you can observe for a 6 month, and when we can investigate during that for the infertility. So that is the one class of the patient who doesn't require any hormonal treatment or any medical management right now. So we can investigate her for infertility, and we can make her conceive by seeing the follicle, the semen analysis reports, and if everything goes normal, so that patient can conceive easily with the IVF. And second is when the patient is having a symptom, typically you know, I am so much worried about the pain and I need that. So there are mainly three treatments which are available. One is a drug therapy, second is a minimal invasive surgery which we generally do as an infertility specialist, and last is the surgery. So minimal invasive surgery is there, in that we can do laparoscopically, we do the aspiration of the peritoneal fluid when there is a collection, then there is a destruction of the endometriotic tissue, means we just have to burn the endometriotic patches which are available or we can see during the laparoscopy there. And second is a new treatment that is called as a Luna, where a laser uterosacral nerve ablation, when the patient is having a severe pain, so Luna can be done. So these are all the minimal invasive surgery, and generally we do when there is a failed drug treatment is there, and when there is a infertility is there, a big endometrioma more than 4.5 centimeter, that time we can remove the cyst. And then recurrent endometrioma is there, means patient is taking a hormonal tablet but still she is not get relieved, so that time also we can do. And when there is a typical chocolate cyst which I told, which is more than 4.5 centimeters, so this patient get relieved by the minimal invasive surgery. Now the my today's topic, which is a non-surgical treatment. So in non-surgical treatment, the first and foremost which we use is a combined OCPIL. So generally we give the hormone to the patient for a 3 month, for a 6 month, and depend ki how her pain is relieving. Because of the hormones, the endometriotic tissue, they get settle the cyclical hormonal changes which is occurring, that will settle after 6 months. Generally the patient have a less pain, so that is the one of the drug. The second which we most commonly use is the oral progesterone, because it is having an anti-estrogenic effect, and because of that patient generally they got relieved by the pain. And third is aromatase inhibitor. In that we use letrozole or anastrozole to the patient for a 6 month, for a 3 month. But definitely it is having a side effect like osteoporotic effect is there when we give letrozole for 6 months to the patient daily. So that is causes a osteoporosis of the bone. So we have to supplement that woman with a calcium and a vitamin D3. And last is GnRH, which we give the hormonal treatment. What it does, it downregulate and suppress the pituitary gonadotropin, and in that the patient is having a less pain because there is a no any hormonal or cyclical changes, because from the pituitary gland only we suppress all the hormones, so the patient feels the less pain. And last drug is RU 486, which we use OD daily for 3 months, and from that also patient get relief from the endometriosis. So being infertility specialist, when the patient come to investigate for the infertility, we generally diagnose around his patient is having endometrioma or they are having the adhesion. So these patient gives a good excellent result for the in infertility. So because there when endometrioma is there, so our first priority is to pick up the follicles. We don't go with puncture and everything, because it will affect the reserve of the patient. And so what we do, we stimulate the patient, we take all the follicles and we make a good embryo. And after that, when we have to transfer it, if the endometrioma is big, then we will remove. If it is not big, if it is not troubling anything, so we can go ahead with the embryo transfer, and they give excellent result for the IVF. So these are the treatment modalities which are available for the endometriosis. And so list means last is the surgery, but that is for those patients which we are completed the family and severe pain even after giving a hormonal treatment, even after doing a minimal invasive surgery, patient is complaining severe pain, she is 40 plus, and that time we can do the hysterectomy. And also these are the last options for the endometriosis patient. So main is endometriosis is not something which we should what we say have fear of that. Definitely it alter our physiology, it alter our hormonal imbalance, it causes adhesions. So that is the reason when there is severe pain during your menses, when there is a dysmenorrhea, please come and show to your gynecologist. You should get investigated on the time, because it causes increasing adhesion, and sometimes it there is a deep what we say the frozen pelvis can be happen because of the severe endometriosis, because there are the grading of endometriosis. So grade 4 is a very severe, patient feels so much pain, and that is the one key we should be alert for that. So this is for today's topic, that is endometriosis, which is non-surgical management. I have told ki we give hormonal medicines and we have to investigate for the reason, and we have to take a treatment for the fertility in these cases. If you have any questions, please let me know so that we can solve. So there is a question by one viewer ki what are the symptoms of endometriosis? So I am telling ki one and the foremost symptom is the pain. That means it is a dysmenorrhea, pain with the menses or pain. Sometimes it occurs lateral. So that is a deep-seated pelvic pain when there is the severe endometriosis is there. So this is the main symptoms of endometriosis. Yes, someone is asking ki can MRI detect endometriosis? Yes, definitely MRI can detect endometriosis, but it is little costly. So the transvaginal scan also can do the same thing. Generally, when there is a grade 3, grade 4, that time we say or we recommend patient to do the MRI. but transvaginal scan is more than enough. Yes, you can have a baby with the endometriosis, definitely. But the thing is, we have to first diagnose what is the grade of your endometriosis. If grade one, grade two is there, definitely you can try with other factors. If it is good, means if your semen analysis is good, uterine cavity is good, and this everything means other factors like a tubal factor means fallopian tube is open, so by means naturally or by doing a IUI or when there is a severe endometriosis, so definitely with the IVF, with that you can have a baby. Yes. This is our helpline number, which is displaying. If any questions you are having, please feel to call, or you can ask, and you can meet also in Oasis Fertility. Thank you so much.